All right, I'm back for another educational YouTube video, and this is going to be a topic specifically on breast augmentation and where we're putting implants in for breast augmentation. So I've had this topic on my YouTube channel before. I've talked about this, fairly in depth. We're going to go a little bit more in depth. We're going to go through the history of breast augmentation. We're going to talk about the history of planes, of how we've evolved our technique of breast augmentation. For those of you watching, this is going to be like a 35-40 minute video. It's going to be pretty in depth, I think. Hopefully I can answer a lot of these questions, and it's been inspired mostly because there's a new plane that's come to the market, and I do have some concerns with it. So what we're going to do is we're going to sit down, we're going to really go over everything. Get your popcorn, get your drinks ready, so we're going to get this started. So the whole point of this is really understanding breast augmentation, understanding the planes and where we're offering implants and placing into the human body. I'm a big proponent of safety and longevity, and educating my patients of what is the best choice for them. So just kind of going back of my experience, I'm a board certified plastic surgeon. I've been doing this for almost 15 years. I specialize in breast and body. I do a lot of this surgery for a living, for aesthetic purposes. I have no financial conflicts with any implant manufacturer or any associated company actually of that. So the audience of who I'm really trying to focus on is really those patients looking to have this procedure. I feel breast augmentation is one of the highest satisfaction procedures we offer in aesthetic surgery. We can give you any kind of look you want. If you want to look very natural to very augmented, and that spectrum all in between. There's tons of different, there's a huge portfolio of implant styles, profiles, sizes, and it's really up to the patient. But it really depends on the surgeon and in their hands, like what they can offer to hopefully match your desires. But I strongly encourage you to focus on safety and longevity of the procedure you choose to pursue with your surgeon. Please do your research. Just don't look up on the internet breast augmentation for $3,500 and just take that. You get what you pay for sometimes, but I'm going to question that statement here in the future. We're going to go back to the anatomy. Let's talk about the anatomy. Super important to understand this because it's going to make a huge impact on how we understand breast augmentation and planes. So the breast tissue is an organ. It's a secretory organ. It lives on top of your chest muscle. This is called the pectoralis major. This big muscle is over your chest. And it is going to cover most of your thorax of the upper body. The breast tissue itself is made of a gland, this glandular tissue, and it's surrounded or encapsulated in this breast fat. The gland tissue is important to understand because this gland tissue is going to make your milk for having children. This is the gland tissue that swells up when you start, increasing your hormones, prolactin, estrogen, progesterone, and so they'll swell up and they'll start producing milk. It's a secretory organ, so what you have to understand, this has a direct connection to the outside world through the nipple, and it inherently has bacteria. This is normal skin bacteria that we have on our bodies. It's also within your gland tissue, and your body sees it as normal. That's why it doesn't react to it. But it's a secretory organ, symmetry like sweat glands. It's also a secretory organ, so it does have a connection to the outside world, and so it's connected. It's kind of encapsulated in this breast fat. So that's what breast tissue is made of, breast fat, and then you have the gland tissue itself. It's going to live on top of your chest muscle. There are distinct layers associated to the chest anatomy, and so I'm going to just point that out real quick. So we have the breast tissue itself, we have fat, we have this layer that kind of encapsulates the breast tissue separate from the subcutaneous fat, which is a fat underneath your skin. And this is called the anterior capsule here, that you can see there. But it also continues posteriorly too. It's just this very, very, very fine layer that kind of encapsulates the breast tissue in total. It really does. It's kind of like an implant shell. And then you have a deeper fascia, which we call the pectoralis major fascia, and that's going to live on the surface of the pectoralis major, which is the white, that white covering that you see on like steaks. It's the same kind of stuff. We call it fascia. What's beautiful about the breast tissue, has this kind of implant concept. It does have this capsule, which we talked about, the anterior lamellar fat or the anterior capsule, also the posterior capsule. Here's the breast tissue itself, and within it you have this beautiful network of ligaments, and they're called Cooper's ligaments. And Cooper's ligaments are basically holding the architecture of that breast shape, as either be perky or it holds all that breast tissue and breast fat all together. It's a very important structure as we get into the evolution of breast augmentation down in a few minutes. But these structures are made of collagen, and then they are susceptible to a couple things. One is enlargement of the breast tissue. With pregnancy, your breasts will feel like they're stretched out. So not just you don't have stretch marks, you're also going to stretch out the ligaments, those Cooper's ligaments between the breast tissue itself. You need to understand that this is a very important structure associated to and unique to the breast gland itself. So we're going to get back to that. But again, revisiting, we got anterior lamella, we have the posterior lamella, which is the posterior capsule, and then you have the fascia of the muscle. So this is a very important anatomy picture. You need to take a picture, look at it in the future. You have vessels within the breast tissue itself. You need to understand all the nerves, all the lymphatics are in the breast tissue itself. Again, this is why the anatomy is important to understand. So let's talk about the evolution. So when we first started out, we started, hey, well, let's do this. It's, by Dr. here in Houston, actually, Dr. Cronin and Dr. Biggs created the breast implant, and they just basically put an implant directly behind the breast tissue itself. They just made an incision along the inferior crease, and they slid the implant in. It's going to live behind all the breast tissue. Okay, that's where they placed it. And then they evolved into another technique called submuscular. We'll kind of go over why. So this is called the subglandular technique. It's under the breast tissue itself. All the breast tissue, all the breast fat, all the breast gland is going to be in front of the implant. This implant is going to live directly, basically on the chest fascia, which is that muscular fascia we talked about. And so when you do that, you augment the breast form or the breast architecture. It just pushes everything out, but all the breast tissue is in front. We do have some issues with that we've learned over the course of evolution of breast augmentation. It's that sometimes just the contact of a lot of breast tissue, which again is that gland tissue, has bacteria. And we've learned with time that it is one of the main risk factors associated to capsular contracture. Capsular contracture is the thickening of that scar bag that forms around an implant. And it's because your body's pissed off because there's a little bit of bacteria where it shouldn't be, which is around the implant. And it's because mostly what we think is because of contamination of breast tissue during the augmentation itself. And so your body starts forming all the scar tissue, gets pissed off. And what happens is you get this very, very hard, round implant look that can be significantly deformed. It can kind of move. It depends on where it started forming. It can be painful. It can be very, very disturbing cosmetically as that contracture evolves. And we think it's because of the fact that we've had contamination of the breast tissue around the implant during the augmentation. And if that doesn't happen with time, what happens is that implant, again, is on the breast tissue itself. And you give it 15, 20 years, and you have a larger implant, you might have this whole descent of the breast tissue itself. And so the whole thing just kind of stretches out. And you're like, well, why does that happen? And the reason for that is that the only thing holding that implant's volume on top of your breast tissue volume is a suspensory ligaments associated with your breast, the Cooper ligaments, and your skin. So there's two things you can't stop. One, it's gravity, and two, the aging process of the human body, where we lose elasticity of our soft tissue. And so this can eventually happen. It might take some time, okay? If you lost a lot of weight, it can accelerate that. So you need to understand this is just the common sense outcome of having more volume on your chest over your chest muscle. And if you don't believe me, go look at women who have very, very large breasts, genetically have very, very large breasts. When you give them 20, 30 years, I promise you their whole breast tissue is descended onto their abdomen, and it's just part of just weight and gravity, okay? So we're like, well, that sucks. We don't like that capsular contracture issue. It really sucks. Let's put the implant as far away from breast tissue itself and decrease the risk of that happening. Let's put it on the muscle. So that's what they did. That's what we did. We started putting implants behind the muscle. And so we noticed that the implant would give a great projection. It gave a lot more fullness, and our contracture rate went down significantly. But the problem with that is that you're augmenting the chest volume of the chest muscle. It's not the breast tissue. They're two anatomically different structures. And so what can happen is that with the implant more covered by the muscle, the breast tissue can slide off. And we have this, what we call waterfall deformity, where the breast tissue just kind of sliding off the implant itself. And it's because you need to understand the implant's being held by that muscle very high, while the gravity and aging process is unrelenting, and what happens, the breast tissue just slides off. And so you can get this waterfall deformity. But we did decrease our capsular contracture rate. So then we got this genius idea, let's combine the two. And that's what we have now, and that's called a dual plane technique. And this is basically halfway under the chest muscle, halfway under the breast tissue. It can be adjusted on how much muscle coverage is covering the implant, so that we have either more exposure to the breast tissue on the bottom over the implant or less. It just kind of depends. This can be a technique that can be modified quite significantly to adjust for the breast shape and form. So we have type 1, type 2, and 3 dual plane techniques. And I would say most surgeons who are doing this procedure currently in the United States, we're using a dual plane 1, where the implant's placed partially under the muscle. We release just the bottom half of the muscle. The rest of the attachment of the sternum of the pectoralis major is still intact, so it still functions normally. But the lower half is just opened up and the implant slides under. And so the breast tissue is kind of on the bottom of the breast of the implant itself. And the rest is going to be covered by the muscle. So a great evolution of technique. We had some great success with it. There are a couple of unique issues with this. Sometimes is that, you know, if you leave too much muscle attachments along the inferior border, this animation can happen where the implant gets pushed up and it kind of pushes, you'll see kind of a weird kind of movement of the chest muscle to the interface of the breast tissue itself. With time, with women who are training their chest, this is, you know, just my soapbox, you train your chest you know, hard enough and give it some time, what happens is that you can push the implant down and out. You can actually, it can go off the side of your chest, down and out. There's really nothing stopping it. And it has a lot to do with just the strength of the muscle, pushing harder and harder and harder, and what it does is push it down and out. So that will require reconstructive surgery where we kind of correct that space issue, and then we can put the implant back to where it used to be. Okay, and then we're like, okay, well, now we started doing this new, well, not a really new technique, but we're calling it a subfascial technique. And this is really taken off in the probably, I don't know, like 5-6 years ago. And it's continued to be more of a favorite, especially with the newer surgeons coming out, that the draw to this is it has less discomfort because you're not, you know, cutting the muscle in the dual plane technique. And it's a faster recovery. And it's very similar to subglandular augmentation. And as far as recovery, very, 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 very similar. But the placement of this implant is behind that white layer of the muscle itself, that fascial layer. And so as learn about this technique, you're going to understand that, you know, as a surgeon, this technique is very, very, very hard to find because that white little thin layer is just so inconsistent, especially inferiorly. As you get more superiorly in the technique, you can see a little bit more of that thin white layer, but it's very, very, very thin. We're talking about like less than a millimeter thick. And so the whole concept of it was that decrease the animation, you have more soft tissue coverage than like the subglandular technique. But in my opinion, subglandular is basically the same because you're talking about like a millimeter of a tissue that's very inconsistent automatically. So the older surgeons will kind of disagree with this subfascial and say really it's subglandular. You know, I'm kind of one of those guys. I think it's pretty much in that sense. But this is a very common technique. I would say this is the new buzzword, is subfascial, because it doesn't, you know, damage the architecture of the chest muscle. So let's kind of go back and kind of talk about these different techniques. So starting from the top, the more superficial plane, and then going all the way to the deepest. So if we look at placement, subglandular is over the muscle. Subfascial is over the muscle, but again, it's on that white layer. A dual plane is a hybrid, and some are completely under. If you look at pain, it's always going to be the least, the more superficial you are. So we got subglandular, which is least, and most uncomfortable when you're completely under the muscle. Recovery, again, fastest is always going to be more superficial. You know, back in the day, they were doing subglandular basically under local anesthesia, which can be done currently now. It's not that big of a deal. But it can be done safely and quickly in a subglandular technique. Subfascial, a little bit more comfortable because you're stimulating the muscle during that plane dissection. Dual plane is a little bit slower, and the slowest is the submuscular. Animation deformity is when that chest muscle is activated and it pulls on the capsule of the implant. It can kind of change the shape of the breast. You're not going to get with anything over the muscle, but you get a little bit of slight risk with dual plane if it's done correctly, and a very much stronger with the submuscular. Rippling has everything to do with how much soft tissue is over the implant itself. We're talking about the skin to the fat, to the breast fat, to the implant. The thinner you are, the more likely you're going to have rippling. The thinner you are and you have an older generation implant, which has more folds in it, just kind of more foldy, you will have more rippling. So implant selection is very important. If you're going to choose an implant that's going to be a subglandular or subfascial, you really want to make sure the right implant with a good fill ratio has that structural integrity to minimize the rippling deformity. Seroma hematoma risk, I would say it's definitely higher along subglandular, and it's really because there's a lot of blood vessels in the breast tissue itself. There's a reason for that, because it's an organ. It's supposed to have a lot of blood supply because you're producing all the milk. Under the muscle, that's much more of we call an areolar plane, and so that plane is much more just looser. And there are some vessels along the medial part of the chest, but those can be easily avoided. Contracture risk, this is what gets us all. This is what drives us crazy, is this capsular contracture risk. And again, has, in our literature, this is for decades now, has shown that there's a contamination aspect of, during the augmentation, that breast tissue contacts the implant, bacteria that we see as normal, that our body sees as normal on the outside of our body, is now on the inside of the body, and our body hates it, and it gets pissed off, and it's not a true infection, but what it does is cause enough inflammation that we start laying down more scar tissue, and you get this contracture formation. And it's going to be the lowest, where the furthest away from the implant, which is under the muscle completely, and then the highest is going to be over the muscle, just under the breast tissue. So what we're going to introduce you guys to now is this new Kool-Aid. It's basically an intraglandular technique. And so this is a plane now that's being marketed by a certain breast implant vendor that we will not talk about, using a special technique of a device and a toolkit to introduce an implant into this plane. So before I kind of dive into this, this is a technique I think that's really unique to a specific dissection and plane dissection with a specific set of instruments. I was trained in this technique. I know how to do it. I've done it. I've done this procedure already, and I have a whole lot of concerns about this. And we're going to kind of go over the anatomy. I want you to focus on the anatomy and just bear with me going through the concept of where this plane is, and then my concerns with doing this plane. So we're going to go back to the breast anatomy. So again, we talked about the gland tissue itself. We talked about the anterior lamella, also called the anterior capsule. We have a posterior capsule also that, again, it's just a big bag that's encapsulating the breast tissue itself. And then within that breast tissue capsule, we have breast fat and we have gland tissue. So with this technique, this implant is being placed directly superficial to the posterior lamella or the posterior breast fascia. And so that is actually in the breast fat itself. This is an implant directly into the gland tissue itself. And the reason they're doing that is because they want this nesting concept. This is going to be one of their buzzwords, nesting, because that implant is now in the breast tissue itself, surrounded by the Cooper's ligaments of the breast tissue. Again, you're in the breast tissue, so that all that collagen network, the suspensory network that's designed to hold the breast tissue itself, is now being asked to hold an implant on top of it to really keep it in a position. And so we're going to kind of go over the issues with this. So this technique is specifically currently being used only with a toolkit that involves a dilator. It involves a balloon expansion process. And so you're going to hear some selling points, and they're talking about under local anesthesia, no pain, smallest incision, no touch technique, and this nesting. And this is going to be a lot of marketing that you're going to see here pretty soon. It's going to be a huge topic of discussion in our society within the next coming years. So I'm going to give you 15 reasons. 15 reasons why I think this intraglandular breast augmentation technique is going to be a problem. And this is why I'm not doing it with my patients. I'm not offering it with my patients themselves. This discussion we'll have more in person, but I think, people need to hear the other side, and you can't say I haven't had the experience, because I've done it. And I came back a little disillusioned, and just kind of had, really just accepted common sense. And I started raising these concerns, and I was, kind of disappointed that the process can continue to push, and it's being pushed even harder. And so I want patients out there who are considering this technique, just understand the anatomy. Just think about where we're at. And this is the purpose of this presentation. So bleeding. So when we did this technique, it's a large dilator. It's about 12 inches, and it's pushed into the breast gland itself, okay, and it creates this channel. And then we're going to put this balloon dilator. It's the same channel width, is about 2 centimeters, and we just push, basically create this space bluntly. It just pushes and expands the breast capsule, the breast tissue itself, where all that ligaments. And the idea is you're nesting. And so, knowing breast surgery, we've been doing this a long time, the breast tissue bleeds. It just bleeds. Those surgeons out there who've done breast reduction, it bleeds. Breast lifts, it bleeds. One of our number one complications with breast lift and breast reduction is the hematoma. And so we're asked to now put this expansion concept into the breast and not expect bleeding. It's not that it can't be done safely without, bleeding. I totally agree. But I cannot accept that you won't have it eventually. You will get it. But the problem is how do you fix it? We have a 2 centimeter incision with this dilator, and we have something that's actively bleeding, and how do we stop that? And that's my concern, right? How are we going to stop that bleeding? If we had a normal incision, I can go in there, find the vessel and cauterize it and close it off, and we can stop it. With this technique, this little tunnel is literally this big. It is impossible to see anything. You cannot see into this tunnel at all. It is too difficult, and I think there's a risk of having a hematoma issue, where maybe you diagnose a bleeding issue before you put the implant in, but most likely you're going to put the implant in, you have this bleeding issue. So how are you going to get that implant out with that 2 centimeter incision? How are you going to stop that bleeding with actively bleeding? Just questions. I don't know how to do that. Local anesthesia. I did this surgery under local anesthesia, and very concerning. There is no general anesthesia machine. In my training, there was just really this IVD sedation. I would say the patient experienced quite a bit of discomfort, but we were kept told it's under local anesthesia, no pain, no pain. I think to do the surgery more safely would be under general anesthesia. I think the patient would be much more comfortable. Our precision of the technique would be higher. I don't like this idea that we're selling under local anesthesia, no pain. I think it's overselling, and I think most of us surgeons who are more focused on safety are going to lean more towards doing the procedure under full anesthesia. Small incision. This incision that they're marketing is a 2 centimeter incision, which is very, very, very small. This is small enough just to get a basically one retractor in, and in my experience, that hole is very small, and the tunnel is even smaller. And what they're doing to kind of help increase the process of the expansion and the placement of future implant is they're stretching this implant. They're using instruments to really stretch that incision. As surgeons, at least plastic surgeons, we're kind of trained on tissue. Just being gentle with tissue, not tear and rip things, and that's exactly what we're doing here. And I think most surgeons who eventually do the surgery are going to basically make the incision bigger to avoid this stretching issue. But the incision typically goes up to 3 centimeters, which I would say most of us, who are experienced, are using 3 centimeters, maybe 3.5 centimeters for most breast augmentation. We can just see better. You have just more visual control of what you're doing. These 2 centimeters are very, very small procedure. And I have a problem with the devices that you're using. This is a blind technique, 100% blind. It is really a very tactile procedure. We are encouraged to use ultrasound to make sure we're in the posterior glandular fat, posterior glandular fat, and it's a feel. You can definitely feel when you're in it, when you're not. But the problem is the chest anatomy is different for every person. So some are more curved, some are more straight, some are kind of concave, and this is a very difficult process. I'm not a weak guy. But doing this was a significant amount of force for me to introduce this dilator into this young lady's breast, and get into where they said it was supposed to be. It's just, I think I pride myself on precision and pocket placement and pocket dissection, and this is really kind of the other opposite end of precision, in my opinion. It's a blind technique. The big push of this procedure is one of the selling points is that it's fast. That you can do the surgery like under 20 minutes. Speed isn't everything. I think I'd rather have someone do a surgery to me that they took their time and were very, very, very precise, versus just saying, I'm going to go as fast, I can do a really fast procedure. You know, especially in the world of local anesthesia procedures, like being fast it may not be all the best thing for the patient. We got to me, it's more about precision. I want a very, very precise placement of an implant. And if I'm gonna have an implant potentially for decades, like that to me makes sense. That to me is common sense. But the selling is it's very quick, and a surgeon can do 10, 15 in a day. I know that's great for revenue generation, but I do think there is going to be some problems, specifically when it comes down to precision of where that implant is going to live for a significant amount of time. This is a big issue for me, is that one of my most common complaints for breast revision surgery is you hear this, especially here in Texas, we hear this, I wish I would have gone bigger. And it happens all the time. And in different markets and different regions of the world, maybe this is not going to be much of a complaint. But this is just the most common complaint we get, is that I wish I would have gone bigger. But what if you have capsular contracture? What if you have like implant placement issues where one's higher than the other? Look, how do we fix that with this technique? You have a 2-centimeter incision, that this is what you're sold. I want a small incision. There's no amount of revision surgery that we can do through a 2-centimeter incision on the breast. Like it's impossible. Like it is impossible to do any kind of significant reconstructive work or scar tissue removal through this 2-centimeter. It's just not possible. We can't see anything. And then it's just a spectrum of revision surgery. What if you want to go bigger? Well, now you have this capsule that's formed around an implant, and then can you stretch it even more? I don't know. Probably not. More than likely not. It won't be as stretched as you would think. If you have scarring around an implant, which I think is to be a significant issue with this technique specifically, how do you get that scar tissue out? The answer is, I'm going to just tell you the answer, is we have to make a bigger incision, and we have to remove that tissue. It's just the way it is. You bought it. There is no other way to do it safely. The revisions issues for this technique is going to be very, very, very high, and I want patients to understand that. My number 8 is it does add volume to the breast tissue itself, to the breast gland. And just like subglandular, exactly like subglandular, not only are you on top of the chest muscle, but now you're in the breast tissue itself. And you're asking your natural anatomy, these Cooper ligaments, the other breast tissue, to now support an extra 200, 300, 400. I'm seeing this technique being done with 400 cc implants. 400 cc implants in the breast tissue itself, and these are ligaments that are designed to really hold breast tissue and breast fat, which is it's kind of light relative to silicone implants. And so I think the evolution of time and gravity, this is going to happen. We're going to get this very low descent of breast tissue itself, and I think patients are going to be very unhappy. That's my opinion. You just can't stop 2 unrelenting forces, which are gravity and the aging process of the human body. Number 7 is placement location. This technique is, when I got trained on, is that they wanted the implant high and in. They really want to put it up here in the center. And the theory is that you augment the volume where you want the volume, which is more upper pole fullness and more medial cleavage, and so that's where they're putting an implant. Well, I guess time will tell whether that implant actually stays there. Because again, their concept is that this implant is being held by the Cooper's ligaments in this nesting concept, and then the implant is going to stay where you put it. I just don't buy it. I think the Cooper's ligaments are not as strong as they hope, and with the aging process and gravity, I think they're going to stretch, and the implant's going to descend a little bit. But I think you will have more gland tissue on the lower pole of the breast. If the implant's here and the breast tissue here, you will get this waterfall deformity that we only have with submuscular augmentation currently. It's going to be an interesting, visible issue in the future, in my prediction with this technique specifically, is that you'll have the implant up here, all the breast tissue is going to be under, if the implant stays where they think it is. I don't know, we'll see. All right, number 6 is implant integrity. This technique, again, it requires a 2-centimeter incision, very, very, very small, tight tunnel, and we're using a funnel to get that implant from the outside world into the breast tissue itself. And so it takes quite a bit of force to get this implant in. And the implant volume, typically we're dealing with this technique specifically, somewhere around 200 cc's. Not a big implant, but it's a very small incision. Me personally, using that same implant vendor, I've had resistance with the funnel at times because the incision is too small. And I pushed on the implant so hard through the funnel that I've caused this issue called blebbing, that I call blebbing, where if you take the implant out and you push on the squeeze implant, it has this weird like knuckle looking thing. And this is a permanent damage to the shell itself. And so I've done this, more than a handful of times now, because I'm stubborn. I'm trying to keep my incisions small. But I do realize I've learned that there's a certain amount of resistance I'm willing to accept before I just have to make the incision bigger to avoid damaging the implant. And this is a real world issue. I know the surgeons have experienced this, and this is a concern with this technique specifically because it's a super small incision. When I did this technique during my training for this technique, I am convinced I did the same thing that implant because I put way more force on that implant than I did putting this one in. And so I don't believe in that the integrity of the implant can be a stable shape and structure, and we're asking for this implant to be with the technique specifically. But what's interesting in the world, this technique is using a different gel of an implant, and it's more viscoelastic, which means it's more of that liquidy kind of concept. So it's more of that injectable implant that they're trying to sell. And so in the world, they have access to much softer gels that are more designed to do this technique specifically. Why they're not in the United States, I don't know. I just don't know. I know there's some associated FDA approval, but we're currently offering this technique with the implant that to me is not the right one for this technique specifically. Pricing. Pricing is going to be, you need to understand that pricing is going to depend on your surgeon's experience, your surgeon's expertise, and the market of where you are interested in breast augmentation. So, Northeast is significantly more expensive, and then like the Midwest, California's be more expensive, than the Midwest. It just kind of depends on where you are. If you're choosing a board-certified plastic surgeon, you should expect more of a price premium because they're more experienced and better trained, versus a non-plastic surgeon, which are like cosmetic surgeons that are not as trained, so they're going to charge less. It can vary. I'm going to take Houston as an example. So we're going to start, usually the bottom end of Houston would be around $4,500 for maybe saline augmentation, to a more senior, experienced, well-recognized, Newsweek surgeon is going to charge, $15,000. With this technique specifically, surgeons are charging 100 to 200% more than their most experienced base technique of breast augmentation. And I don't understand it. I just don't get it. But this is going to be something that patients should expect. If you want this technique, you're going to charge you're going to be asked to charge another 100 to 200% more than you would just our normal, safe, branding surgical technique of breast augmentation. So that way that you know what you're getting into. Number 4 is I have a concern for mastitis with the technique. Going back to the anatomy, breast tissue is composed of breast fat and the breast gland tissue. Women who get pregnant sometimes will get clogged ducts of the gland. And I'm told from my patients who've had it that it is one of the most painful things that can ever happen to you. It is extremely, extremely painful. A lot of pressure, a lot of pain, like super painful. I don't want to experience it. But it happens to clog ducts. And again, because the gland tissue itself is a secretory organ, has bacteria, you get this infection. The problem with this technique is we have an implant not just under the breast, it's in the breast tissue, people. It's in the breast tissue. It's right next to the gland tissue. Less distance between gland tissue and the implant. It's right next to it. Couldn't be any closer. Might as well just hug up to it. It is right there. And my concern is that implant is going to get an infection around it. And the way we treat that currently is we take the implant out, get the infection cured, get them on antibiotics, get them well. And that is another surgery I think that can cause a lot of deformity. It can cause a lot of pain and suffering in the future. And I think we need to understand why we're doing it. Why are we putting an implant directly in the breast tissue? Higher chance of capsular contracture. This is my prediction. I'm not going to say it's supported by the literature, but this is my prediction. This is my opinion. Based on the decades of research we have of breast augmentation, knowing what has a higher capsular contracture risk, whether subglandular versus submuscular, we know that the closer you are to the breast tissue, the higher the risk is going to be. It doesn't matter the implant surface. There's just no way. It's a foreign device. I think we are going to have more contamination in breast tissue because we're in the breast tissue, remember? and there's going to get this contracture formation, and this is going to be a problem in the future because we're going to be asked to do revision surgery on it, and then you're not just, you know, damaging the architecture of the breast tissue. I think you can deform it significantly because you're in the breast tissue itself, and requiring us to remove that implant and all the scar tissue even more disruptive to the natural architecture of the breast tissue itself. And so I think this is going to show its true numbers of capsular contracture risk, you know, in the next 10 years. Currently they only have 3 years of data associated to this. I think it's going to be much higher. I think it's actually underreported significantly. Number 2, we're almost at the end. Hang in there with me. This is a huge problem with me, mammogram. You know, when we were trained on this technique, we asked the radiologist who was instructing us, you know, what happens if you have breast tissue behind the implant? Because again, this is a blunt dissection, and you might, you know, aim a little superficial, because someone who's jamming a spear into your chest, we tend to want to aim more superficial and not go into your chest. And there's this natural safety kind of mechanism of trying to go up versus down to stay under the breast tissue. And what happens, you can put the implant directly into the breast tissue, and there might be some breast tissue behind that implant. It's probably going to end up on the top part of the breast, and the radiologist will be like, there's something back there, the implant is disformed, I can't see everything, we need to get a MRI. Not an ultrasound. We can't do an ultrasound because you can't ultrasound underneath the silicone implant. You have to get an MRI. And that's what they recommended to us, is that patients should get MRIs, and if they have this technique specifically, if they have issues with not being able to see breast tissue. I just don't see that as a realistic diagnostic screening modality for women with breast implants, when we've had decades and decades of research showing that breast augmentation can be done safely and have normal routine mammography in the current techniques we have. And the reason for that is because the implant is living directly in the breast tissue. I just don't, this doesn't make sense to me. Even with the evolution of technology, I just don't see that having an MRI is what we should be doing for women for diagnostic screening. And the number 1, say with me, we're intraglandular. There is nothing about preserving breast tissue when you're in the breast tissue itself. You're actually tearing and stretching and disrupting the architecture of those amazing suspensory ligaments called Cooper's ligaments, and you're putting this heavy implant into it, and you're stretching and you're pushing it where it doesn't want to be pushed, and you're adding weight. There's nothing about that that's preserving the natural architecture of the breast. Nothing. I don't understand this preserving word, that saying that this is preserving breast tissue. You're in the breast tissue itself. I understand you want to nest, and I understand the concept of nesting. It sounds great, but the nesting is because you're depending that the collagen of the Cooper ligament to hold that implant up. It's just not designed for that. The breast tissue is not designed to hold an implant. You know, it just doesn't happen. I do not think that this concept of preserving the breast tissue is valid in this technique specifically. Yes, you're preserving the muscle from disrupting the muscle. Yes, you're preserving the fascia of the muscle. I agree with that too. That's chest preservation. It's not breast preservation. It's the exact opposite. You're disrupting everything about the breast gland. You're disrupting the nerves, you're disrupting the suspensory ligaments, you're disrupting the lymphatics of the breast tissue. Everything about the breast tissue, the implant's directly, bulldozing into. This is my number 1 problem with this technique of the intraglandular placement. I do not think it's a viable technique in the future. Time will tell. So going back to the comparing of planes again, now I'm going to add another column here for you. We talk about placement, the post-op pain, recovery, animation, deformity, rippling, stroma risk, and capsular contracture. It's the same ones we talked about earlier. New one, new column, new technique, new plane, intraglandular. This is in the gland. Least pain, similar to subglandular. We're going to have a fast recovery, okay? No animation deformity because you're in the breast tissue itself. The breast tissue doesn't have any muscle in it. I think the risk of higher rippling is there. I think it's going to be the highest because you're even closer to the skin than if you were subglandular. You're much, much closer now because you're in the breast tissue itself. I think the risk of having issues with seroma because of the lymphatic disruption and the bleeding, again, is going to be higher with an intraglandular. You're in the breast tissue. And the capsular contracture, You know, time will tell if this is correct, but I think it's gonna be the highest because you're in the breast tissue and you're gonna be directly sitting up next to the gland tissue itself. So, choosing what's right for you. Talking about you patients, the most important decision is not the name of the technique, but the surgeon you choose. I cannot emphasize that enough, you know. Please go seek a board certified plastic surgeon. You're gonna have the highest chance of having the proper credential and experience in the training. You know, ask them about their experience. You should not be offended as a surgeon if they're asking you about your experience and you're familiar with the different techniques. Discuss personalization of, you know, what is the right technique for you, you know, the pros and cons. You know, breast augmentation is really not that simple. I think it's actually fairly complex. If you understand that you really do understand anatomy, you understand the asymmetries of every patient, the unique characteristics of different patients, and make sure your aesthetic alignment is correct with what your surgeon is offering you. Cannot emphasize that enough. It's so important that you choose the right surgeon. Do your homework, do your research. So, thank you for sitting through all this. I hope you learned something. A lot of anatomy, a lot of evolution of breast implants technique. You know, I'm sure it's going to create a lot of questions in the community, which I'm more than welcome to take. Love to hear from you. This is going to be a hot topic for the aesthetic plastic surgeons at the aesthetic meeting in 2026. And this is going to be a debate issue on most likely within several panels of that society meeting. We hope that we can do this technique safer. That's what I hope, that it has inspired more surgeons to really kind of look at the safety and anatomy of breast augmentation, you know, whether they offer it, whether they don't. But interesting, at the light in the tunnel, it has introduced a new technique. And that is what I've already talked about before, about breast augmentation with fat. And so I think that posterior glandular fat plane, I think it's going to be a brilliant plane for fat augmentation for breast surgery. And I think that's the light at the end of the tunnel of all this. So anyway, I hope you learned something. Again, don't forget to like and subscribe. Love to hear from you. Drop a comment down below. I'd love to hear your questions, and thanks for watching.